Now, the first section on the cardiovascular section of the blueprint is over cardiomyopathy. There's three basic cardiomyopathies that you need to be familiar with when you're taking the NCCPA: dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. Now, looking at them on the surface, each of one of them have their own intricacies and their own things worth remembering. Um, let's dive into dilated cardiomyopathy first. Dilated cardiomyopathy, it's important to point out, of the three cardiomyopathies that we're going to be concerned with for the exam, it's the only one that has systolic function that's impaired. Um, it can involve one or both ventricles. Think of the ventricles as being enlarged and going from these really normal sized atria to these extra large ventricles, and kind of blood just kind of slushing around in them. The thing you have to be familiar with is the causes. Now, there's a huge laundry list of causes, and I would say, in terms of the exam, what I would focus on is just being able to recognize these and pick them out, not necessarily have them memorized. They list the causes to be genetic: thyrotoxicosis, starvation. It can be peri or postpartum, cobalt ingestion, sarcoidosis, radiation, hemochromatosis, thiamine deficiency, alcohol, catecholamine-induced, infectious, which can be viral, parasitic, and/or radiation. Big picture item, I would just, point out that, this can be, it can be idiopathic, or it can be caused by ingestion of toxins or radiation or infection or metabolic disorders. When you look at a patient with dilated cardiomyopathy on physical exam, it's going to be similar to the patient, how they present with heart failure. The EKG, you would see some left ventricular hypertrophy or right ventricular hypertrophy. Of course, diagnosed by echocardiogram. The only thing that you consider is cardiac biopsy for is that those who suspect might have a treatable cause. Treatment is similar to similar to heart failure, targeting increasing preload and decreasing afterload. So that's where the ACE inhibitors and beta blockers come in. Think of the ACE inhibitors as being these potent vasodilators that make it easier for the heart to pump the blood out, and reduction of things, and the beta blockers kind of slowing things down, so give the heart a chance to fill efficiently and make each beat more efficient, thereby improving preload. The next thing that we need to look at is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, you got to think of it as this thickened interventricular septum that is basically causing outflow obstruction and diastolic dysfunction. It's almost like it's a stiff ventricle. It has a normal or small left ventricular size. The thing to remember about this, why it causes diastolic dysfunction, if you're going to detect a murmur on a physical exam, it's going to be a decrescendo systolic murmur. I would probably, in terms of the exam, I would probably just focus on it just being a systolic murmur, and you may have an S4 and S3 gallop, due to the ventricular stiffness problems that are associated with it. Another thing to remember about it, it's, of all the cardiomyopathies, it's the most likely to cause life-threatening arrhythmias. Again, the most common symptom is dyspnea on exertion, similar to someone that would have, you would see with CHF too, but you don't have a lot of more of edema concerns on things like that. These patients also may have exertional chest pain rather than actual coronary artery disease, but due to the ventricular septum impeding the blood flow out of the heart and decreasing the perfusion of the coronary arteries. Syncope or dizziness may be present, and that kind of makes sense. If you have a patient that's it has basically a flow block or being slowed down or impaired coming out of the left side of the heart. The great vessels aren't going to be perfused as much, and thus decreasing cerebral perfusion. So another interesting side bit, these can also be asymptomatic. So you have a wide variety of symptomatology associated with it. They may not even have any symptoms, and they can have life-threatening arrhythmias and present with syncope or even exertional chest pain. And of course, with all cardiomyopathies, an echo is needed for diagnostic confirmation and to determine the severity. Typically, when you detect these, they're in older people that you may be you may be concerned for heart disease. So of course, you'd have to do a cath to rule out concomitant heart disease, because it's possible to have more than one thing associated with it. Treatment is also targeting diastolic dysfunction. So beta blockers are good to treat. I misspoke. Calcium channel blockers are ideal. Calcium channel blockers in general, anytime there's any diastolic dysfunction, they improve improve things. Calcium channel blockers in general, dilate the arterial side, and they also have, because they're smooth muscle activity, relaxing the smooth muscles help improve diastolic dysfunction. Beta blockers can be used also to help increase preload and allow the ventricle to fill better. The next thing we need to do is switch gears and look at restrictive cardiomyopathy. This is the last one we need to talk about. Now, this one also has diastolic dysfunction. So, in terms of the exam, when you look at this, keeping your mind that it's restrictive and hypertrophic cardiomyopathy, the two cardiomyopathies that essentially we're dealing with the small ventricle. Those are both going to have diastolic dysfunction. So dilated itself has systolic dysfunction. The curious thing about this cardiomyopathy is the systolic function is normal. The thing that I would keep in your back of your mind for the terms of the exam is amyloidosis is the leading cause. Again, with any of these, when we're looking at the causes of them, I would just I would not necessarily try to remember, in terms of the exam, the whole entire laundry list and be able to list them out. I'd be able to recognize them. And the other causes is idiopathic. They can be idiopathic, be caused by sarcoidosis, hemochromatosis, radiation, scleroderma, and Gaucher's disease. With this type of cardiomyopathy, you're going to see right heart failure symptoms present, dilated neck veins, and sometimes you'll have to perform a right heart catheterization, make sure there's no evidence of constrictive pericarditis. These diagnoses are oftentimes difficult to separate. As with all the cardiomyopathies, as I said before, echo is needed to establish the diagnosis, and treatment is similar to those in heart failure. However, on this one, we tend to focus on, because there's no systolic dysfunction, but we're going to add diuretics to help decrease systemic vascular resistance. To sum things up, dilated cardiomyopathy, you see systolic dysfunction may affect one or both ventricles, and the chambers are large. Symptoms are similar to CHF. You have dilated chambers. Hypertrophic cardiomyopathy is a diastolic problem where you have small chambers. Remember, we're kind of, in terms of, for memory's sake, we're going to kind of almost relate this to restrictive cardiomyopathy. Both have small chambers, small ventricular chambers, and they both have diastolic dysfunction. But the thing to remember, hypertrophic cardiomyopathy, it has a systolic murmur associated with it. It can present as dystonia, exertional, and chest pain with activity. Remember, this is the one where we have the thickened interventricular septum, sort of causing outflow obstruction. Restrictive cardiomyopathy, it's a diastolic problem, small chambers, elevated right heart pressures. Amyloidosis is the most common cause, and treatment is similar to heart failure. Only in this one we're going to focus on